topics in the subject of oral pathology. See, basically, if you see, um, the questions usually which appears, some of the questions which appears are usually like the case history based question, or related to something like the case history based question, or related something like the image based. So priority for today will be such questions where we are going to discuss. Now, the first question says that a mother came with her child after 4 days complaining with abdominal cramps. So the main problem here is abdominal cramps and hypersalivation. So the point which we need to clinch is the mother tells that the child is having abdominal cramps, hypersalivation with rashes. A mother and with rashes. On examination, there were rashes on the palm and soles of the feet along with generalized gingival inflammation. The child is suffering from. So if you see that, what is the clue that we are going to see here? The clue that we are going to see here is, first of all, there is abdominal pain. Second, there is increased salivation. Third is there is gingival inflammation. Inflammation, there is gingival involvement, and skin rashes are there. So if you see this, typically such features are suggestive of heavy metal poisonings. So how to exactly identify this is a patient of heavy metal poisoning, or could it be any skin disease? So if it would have been a skin disease, there would not have been any abdominal cramps or hypersalivation. Like how pemphigus is associated with hypersalivation, there is no clue. How Lychen Planus, how psoriasis, you can't find out any relation between hypersalivation and psoriasis. Hypersalivation Lychen Planus, hypersalivation pemphigus, there is no relation. So clearly by exclusion principle itself, we can answer that it is heavy metal poisoning. Okay, now in this heavy metal poisoning, actually it is because of mercury poisoning. It is because of the mercury poisoning. Now let us go into little more details of this. What exactly is this mercury poisoning? We know that mercury poisoning is also known as acrodynia, or pink disease, or swift disease. So these patients usually exhibit profuse salivation, extremely sensitive gingiva with ulcerations. So the correct answer for this question should be heavy metal poisoning. Okay, so don't get confused with pink disease and pink tooth. Pink tooth is seen in internal resorption, whereas pink disease is the other name for acrodynia, or the mercury toxicity, or nothing but the mercury toxicity. So if we should be aware of certain poisonings actually. So this is one mercury poisoning which we have seen. So usually remember the combination of this abdominal pain and hypersalivation is typical of mercury poisoning. There are certain actually typical MCQs that are asked in metal poisonings, like for example, in arsenic poisoning, we see basically the raindrop pigmentation. Raindrop pigmentation. Okay, so in arsenic poisoning, and in plumbism. What is plumbism actually? Plumbism is the other name for the lead poisoning. Lead poisoning. And we have to remember that lead poisoning produces a line on the gingiva called as Burtonian line. Please remember these MCQs. These are two typical MCQs that are frequently asked. So arsenic poisoning associated with a raindrop skin pigmentation. Plumbism is associated with a lead poisoning or Burtonian line. Lead poisoning or Burtonian line. Remember, if you see lead poisoning patient, the typical systemic manifestation that is associated with this will be peripheral nerve involvement. In the history, they will give history of peripheral neuritis. Peripheral neuritis. So this is a very important point you have to remember. So plumbism is associated with the peripheral nerve involvement or peripheral neuritis. Peripheral neuritis. Okay, so that is the metal poisonings that we are supposed to remember. That is the mercury toxicity, arsenic poisonings, and the plumbism. Now let us move on to the next question here. The next question says that a silogog is an agent used to silogog. Silo means saliva, gog means increase. So silogog is an gog. What is the literal meaning of gog? Gogue. It is nothing but the meaning stimulant. So silogog is an agent which increases the flow of saliva. Now the question comes, when is this stimulation required? When is this stimulation required? Whenever there is xerostomia. Whenever there is xerostomia. What is xerostomia? Xerostomia is nothing but dryness of the mouth. Xerostomia is nothing but dryness of the mouth. Like we have dryness of the mouth in Sjogren syndrome. We have dryness of the mouth in Mikulic's disease. In such conditions, there will be dryness of the mouth. So, in such cases where there is dryness of the mouth, we need to give an agent which stimulates the salivary production. Such agents are called as silogogs. So nowadays, with the increase in the advancement in the pharmacy industry, these silogogs will come as chewing gums. Okay, they come as chewing gum. So usually these xerostomia patients are given these chewing gums. They are asked to chew that. So with that help of that chewing gums, there is increased salivary secretion. One of the famous agent that is silogog, which is frequently used, is the pilocarpine. Please remember this. Pilocarpine is used in the treatment of xerostomia, or they can ask you in Sjogren syndrome. Which of the medication can be useful in the treatment of Sjogren syndrome? Then your answer should be pilocarpine. So remember, pilocarpine is a parasympathomimetic agonist, which is used as a silogog, that is salivary secretion stimulant. They are typically used in the treatment of xerostomia. Okay, so this is what you have to remember about the drug pilocarpine. Okay, now let us move on to the next question. Facial nerve is involved or facial nerve paralysis is seen in which tumor? It is seen in which tumor? The question says that there are certain salivary gland tumors that is benign as well as malignant. So some of these benign or malignant salivary gland tumors usually can show this facial nerve involvement. Which is that? So point you have to remember that is facial nerve is involved in case of malignancy. Remember that in case of malignancy, it is not involved in benign. Okay, that is very important point. Suppose there is a pleomorphic adenoma, and typically in pleomorphic adenoma patients, you are not expected to see the facial nerve involvement. However, in a pleomorphic adenoma patient, if you see a facial nerve involvement, that means that suggests that malignant changes have occurred in that pleomorphic adenoma. Now that tumor is not just pleomorphic adenoma, it is carcinoma X pleomorphic adenoma. Carcinoma X pleomorphic adenoma. That means the pleomorphic adenoma has got converted into carcinoma. Okay, so that is the typical feature of any salivary gland malignancy. So in this options, they have given Wardin's tumor. No, Wardin's tumor is benign. There can't be any facial nerve involvement. Pleomorphic adenoma or of the parotid gland. No, that's also wrong. Epidermoid carcinoma. Yes, of the parotid gland. We can expect, that is what I have told you, malignant. Benign lymphoepithelioma or Mikulicz disease. No. So the correct answer is epidermoid carcinoma. So facial nerve paralysis is a typical feature of malignancy. All other options that are given are benign. Only epidermoid carcinoma is malignant. So that is one which causes the facial nerve paralysis. That is the one which causes facial nerve paralysis. Okay. Moving on to the next question. See, in this option, they have given epidermoid carcinoma. They can give any other malignancy also. In the option, they could have given any other carcinoma X pleomorphic adenoma. They could have given. Okay, they could have given the lymphoepithelial carcinoma. Any of the carcinomas which involve parotid gland can cause this facial nerve paralysis. So facial nerve paralysis, which is seen, is a typical feature of malignancy that affects the salivary glands. Okay. Let us move on to the next question here. The next question is, bilateral mandibular involvement is seen twice in. So the question here is mandibular involvement as well as bilateral. That means both the sides mandibular involvement is seen in cherubism, CGCG, osteoma, Lychen Planus. See, first of all, Lychen Planus we can rule out easily because Lychen Planus is a skin disease. It doesn't involve bone. Now cherubism, CGCG, osteoma. Let us see one by one. Let us see CGCG. Does CGCG affect both the sides of the mandible? No. CGCG is the one which typically affects anterior mandible. For example, this is a mandible. CGCG typically affects anterior mandible crossing the midline. This is CGCG. But here they are saying bilateral. What do you mean by bilateral? Both the sides. Here also it is involving. Here also it is involving both the ramus. Sorry. So typically it is a feature of cherubism. Cherubism is nothing but cherubism is basically a type of the basically the It's a type of fibrous dysplasia where it is autosomal dominant. Typically, it is a multilocular lesion. It is a bilateral lesion. Seen in children. Okay, and usually there will be floating teeth appearance because of the multilocularity, because of the destruction. There will be floating teeth appearance. Usually, this cherubism is not treated aggressively. There will be swelling. There will be expansion. Okay, there will be swelling. There will be expansion of the mandible. You will see swelling of expansion of the mandible, but there won't be any aggressive behavior. Cherubism doesn't get converted into any malignancy. So usually cherubism is not treated that aggressively. What usually you do in cherubism is just wait and watch policy. You just need to follow up the child. With the after puberty, this expansion or swelling usually stops. It is non-neoplastic. Remember, cherubism is non-neoplastic, and it is a type of fibrous dysplasia. Okay. Now, a true cyst that is derived from stellate reticulum and develops in place of tooth is known as a true cyst that is derived from stellate reticulum and develops in place of tooth. That means, for example, if there is mandible like this, you are going to see a cyst here where actually there was supposed to be a tooth. So in place of that tooth, you are going to see that cyst. That is nothing but your primordial cyst. So actually, what the WHO says that primordial cyst, the cyst that occurs because of degeneration of the stellate reticulum. It occurs where the tooth was supposed to be seen. But now WHO says that there is no such cyst. Actually, primordial cyst is nothing but OKC, odontogenic keratocyst only. But still, from the point of view MCQ, you have to remember that it is a cyst which occurs in place of tooth. It is due to cystic degeneration of the stellate reticulum. Okay, of an enamel organ before calcification. So before the tooth calcifies, whatever stellate reticulum is there within the enamel organ, that stellate reticulum will undergo degeneration. Because of that degeneration, you are going to see a cyst formation, and that cyst is nothing but the primordial cyst. So as you are seeing degeneration of the enamel organ itself, there won't be any tooth. Obviously, in the place of the tooth, you are going to see a cyst. So a cyst which is seen in place of tooth due to cystic degeneration of stellate reticulum is nothing but primordial cyst. This is the concept actually. But accepted concept is there is no such cyst. It is OKC only. It is so now the recent concept says that primordial cyst is equal to odontogenic keratocyst. Now let us move on to the next question. Which of the following are associated with increased risk of osteosarcoma? All of us know that osteosarcoma is a malignancy of bone. So typically the Paget disease and polyostotic fibrous dysplasia are the two important conditions which are associated with the increased risk of the osteosarcoma. We have to remember that Paget disease, which is a disease of bone, and polyostotic fibrous dysplasia can have a potential complication, can have a risk of potential complication of developing the osteosarcoma. What are the other causes or conditions where you can see the osteosarcoma development. So one of the important one is the Paget disease, which we have already seen, polyostotic fibrous dysplasia, which we have seen. There is something called as chronic osteomyelitis. Sometimes chronic osteomyelitis is also very risky. It can lead to the osteosarcoma. Radiation to the bone. Radiation to the bone is also a complication. It can lead to osteosarcoma. Multiple exhaustosis. We know that particularly the maxilla, buccal surface, you are going to see multiple bony projections. That is nothing but exhaustosis. So hereditary multiple exhaustosis can be seen, which is also a risk factor or a predisposing factor for the osteosarcoma. So the points you have to remember that particularly these two are most important one. Paget disease and polyostotic fibrous dysplasia are the two very important one which are considered to be the predisposing factors for the osteosarcoma. Okay, let us move on to the next question. Which of the following is not true of a fixative? Is not true of the fixative. 2% formalin is used, kills microorganisms, used as a fixative, prevents autolysis. All are correct except 2%. Actually, it is not 2% formalin, it is 10% neutral buffered formalin is used. You have to remember the percentage. Fixative that we usually typically use is 10% neutral buffered formalin. It is called as NB, neutral buffered formalin. That is the most common fixative used. What is fixative? I'll just explain it. A surgeon, when he does a biopsy and he wants to diagnose what exactly is that tissue, after the excision biopsy, he will put that specimen in a chemical. That chemical is called as fixative. What that fixative will do? That fixative is going to fix. What it is going to fix? It is going to fix all the tissues in a life-like manner. Sethi, tissue has been removed from the body. Now it can undergo degeneration. It can undergo bacterial decomposition. That is nothing but as putrefaction. We don't want that. We want that tissue outside the body also in the same manner. So we want that life-like appearance. For that, we use a chemical called as the fixative. So fixative are very important agent which kills the bacteria, it fixes the tissue, it prevents autolysis. Thereby, you can see that tissue properly under the microscope. Otherwise, what will happen if you don't put, for example, instead of fixative, I'll place the tissue in a saline. What will happen? That tissue will get decomposed. Bacteria will attack on that tissue. It will undergo autolysis, putrefaction. Then I will not be able to see the histology properly. For the histological diagnosis properly, chemical that is used is fixative. Remember, for light microscopy, this is the most common fixative that is used. If we want to diagnose it under a light microscope, any lesion, we need to use 10% neutral buffered formalin. If I have to diagnose it under electron microscope, I have to use glutaraldehyde. Sometimes we need to use glutaraldehyde or osmium tetraoxide. Osmium tetraoxide. So these are the two important chemicals that are used for electron microscopy. Okay, so these are two very classical MCQs that we're supposed to remember. One that is the for the light microscopy, that is 10% neutral buffered formalin. One that is used for electron microscopy, that is glutaraldehyde or osmium tetroxide. Okay, now let us move on to the next question. Burning sensation of the tongue can be seen in all except. Burning sensation of the tongue is also known as glossopyrosis. Remember, the word pyrosis means burning. Pyri itself in the Latin means burning. Glossopyrosis, burning sensation of the tongue. What do you mean by glossodynia? If the patient says that there is a pain in the tongue, we should call it as glossodynia. Stomatopyrosis. If the patient says there is burning sensation of the mouth, that is called as stomatopyrosis. Stomatodynia. If the patient says that there is a pain in the mouth, that is called as stomatodynia. So you have to remember these four terminologies: glossopyrosis, glossodynia, stomatopyrosis, stomatodynia. So this burning sensation of the mouth or tongue is typically seen in all of these conditions except ranula. So where all we can see xerostomia. Of course, xerostomia is very typical. Wherever there is any dryness of the mouth, there is no saliva, the patient will complain of burning sensation. Chronic irritation, contact stomatitis, oral submucous fibrosis, diabetes mellitus. In OSMF, typically the patient complains of burning sensation. Usually normally everyone will complain of burning sensation on eating any spicy food, right? In case of OSMF, even though the food is not spicy, but still they will have more burning sensation. That is very classical. Okay. Diabetes patients also will have burning sensation of the mouth. HIV positive patients, vitamin deficiency patients, pernicious anemia, and one more which I have forgot in this list, you have to write down: Lychen Planus. Typically, Lychen Planus patients complain of burning sensation of the mouth. Burning sensation. There are many types of Lychen Planus actually. Erosive Lychen Planus, atrophic Lychen Planus. Those are the types which usually complain of burning sensation. Not the reticular Lychen Planus. Usually we see the most common type of Lychen Planus, that is a reticular Lychen Planus. And reticular Lychen Planus patients won't have burning sensation. Burning sensation is a feature of atrophic or erosive Lychen Planus. Atrophic or erosive Lychen Planus. Okay. Now, in spite of, other than this, there is one more important syndrome that we should remember, that is called as burning mouth syndrome. What exactly is this syndrome? Try to concentrate on this. This is a very important concept. Burning mouth syndrome. Okay. Typically, understand this scenario. Patient is a female patient, post-menopausal. That is, the patient is in her 50s. Patient comes to you with a complaint of burning sensation of the mouth. When you clinically examine the oral cavity, you don't find any abnormality. There is no abnormality associated. Mouth is totally normal, but patient is having burning sensation. Next, what you will think? Patient could have some anemia or something, vitamin deficiency. You check for that, biochemical findings. Those biochemical findings are also normal. So you are going to exclude all these causes, but still the patient is having burning sensation. That is called as burning mouth syndrome patient. What exactly is the cause is idiopathic. You know, they tell that actually the cause is not known. Whenever the cause is not known, you tell it as idiopathic. It's very easily used terminology. Idiopathic. That means you're not able to identify the cause. You're not able to identify the cause. Typically in a burning mouth syndrome patient, the burning sensation will be affecting the tongue. Burning sensation will affect the tongue. Okay, so burning mouth syndrome patient usually complains of the tongue involvement, that to the tip of the tongue involvement. Tip of the tongue involvement. In exfoliative cytology for oral cancer, not true is, next question. In exfoliative cytology for oral cancer, not true is. What is exfoliative cytology? First of all, it's a simple test. Whenever I can do this test at the chair side, I don't require any technology for this. I'll use ice cream stick. All of you know that about ice cream stick, which is a typical wooden stick. Okay, I will just scrape the buccal mucosa with that stick. I will take that stick, then I will make a smear on a slide, and I will see that smear under microscope. That is exfoliative cytology. It is also called as a scrape cytology. Why it is called a scrape cytology? You are going to scrape the superficial cells. Now understand the concept. In a epithelium, what are the various layers? In an oral epithelium, we have 4 layers: stratum basale, stratum spinosum, stratum granulosum, stratum corneum. The surface layer is called as stratum corneum. So in exfoliative cytology, we are going to get only the surface cells. We are not going to get the deeper cells. So cells that includes transepithelial is wrong. What do you mean by transepithelial? All the layers, from all the layers, stratum basale, stratum spinosum, stratum granulosum, stratum corneum, all layers you will get in exfoliative cytology. No, you will not get it. Only in case of brush biopsy. There is a technology called as brush biopsy, which has been actually devised by an American company called as CDX. So this in this brush biopsy, they will use a brush typically like this. Okay, typically like this. This brush, they will actually press it on the oral mucosa and rotate it 360 degrees. In such case, you are going to get the transepithelial cells. That means all the layers. In case of exfoliative cytology, you will get only the surface cells. You will not get the deeper cells. That is why if you want to see any abnormality in the deeper layer, exfoliative cytology is not useful. Exfoliative cytology is not useful. That is what is discussed here. In exfoliative cytology, only superficial cells are taken. However, in oral brush biopsy, all the layers of the epithelium are taken and analyzed. That is why it's called as a transepithelial. Transepithelial. Okay. Now, can we use this exfoliative cytology in other conditions also? Can we use this exfoliative cytology in other conditions? Yes, we can use this in case of the oral cancer diagnosis, oral pre-cancer diagnosis, herpes, pemphigus, candidiasis. All these are the conditions where we can use this. Okay, So the exfoliative cytology, it can not only be useful for oral pre-cancer diagnosis, oral cancer diagnosis, we can use it in the fungal infection, that is candidiasis, we can use it in viral infection, that is herpes, we can use it in skin condition, that is pemphigus. In pemphigus, we can see the Zank cells. So the cytology that we are going to see there is Zank cells. Okay, that is about the exfoliative cytology. Now let us move on to the next question. True microdontia in maxillary lateral incisor is known as. So what is microdontia? Smaller teeth. Typically you call it as peg-shaped laterals. Usually microdontia is localized and most commonly it affects the lateral incisors, and those lateral incisors are called as peg laterals. Peg laterals. Okay, so usually the lateral incisors are like this. So this is the incisal edge, okay, and this is the cervical surface. So usually the mesial and the distal surface, they in the peg-shaped lateral, they will converge towards the incisal surface. This is called as peg-shaped laterals. Peg-shaped laterals. Cheesy molars, Hutchinson's teeth, Mulberry teeth. That's not true. That's not the typical term that is used for the localized microdontia of the maxillary lateral incisor. Next, we are left over with two more questions for the discussion today. Hemorrh spots are seen in. First of all, we should know that there are two spots you should remember. One is Copic spots, one is Hemorrh spots. Copic spots is the one that is typically seen in case of measles. That is typically seen in case of measles. Copic spots. Usually you would see it on the buccal mucosa, and you usually see it on 2 days before the skin rash. That is the importance. Remember, that's the importance of the dentist. If a dentist is able to diagnose the Copic spots, he can diagnose measles before the patient develops fever or skin rashes. Okay, so those are called as bluish shaped dots that are seen on the buccal mucosa. That is your Copic spots. Now similarly, we have the Hemorrh spots. Hemorrh spots is typically seen in case of rubella. Rubella is also known as German measles. German measles. Okay. Usually you see color is important. See, color and location. If I want to make a table, Copic spot one side and Hemorrh spots on one side. Where do you see Copic spots? What is the condition where you see Copic spots? Copic spot is typically seen in case of the measles, whereas Hemorrh spots are seen in case of rubella. What is the color of the lesion? Typically Copic spots are bluish colored lesions, whereas Hemorrh are red shaped lesions. What is the location where you see this Hemorrh spots? Location of Copic spots is typically the buccal mucosa. Hemorrh spots are seen on the soft palate and the uvula. Soft palate and uvula. Okay, so you have to remember this table. This table is very important, where you can compare the Copic spots with the Hemorrh spots. Okay, so Copic spots, where do you see them? What is the color of the lesion? What is the location? That is what you have to supposed to remember, and you're supposed to discuss about the Hemorrh and Copic spots. Next, let us move to the last question here. Last question for the today's discussion is tennis racket appearance is seen in. What is tennis racket appearance? Tennis racket is a radiographic feature that is typically seen in case of odontogenic myxoma. All of us know that there is one important we can say the odontogenic tumor which is very aggressive, which after amyloblastoma. Amyloblastoma is obviously very aggressive tumor and it has got soap bubble or honeycomb appearance. Odontogenic myxoma is also aggressive. It has got a tennis racket appearance or step ladder pattern. What do you mean by step ladder pattern? Actually the trabeculae are like this. They are arranged parallel to one another. So this arrangement is called as the step ladder pattern. And this step ladder pattern or the tennis racket appearance is a feature of the odontogenic myxoma. Amyloblastoma has got the soap bubble appearance or honeycomb appearance. CEOT has got a snow-driven appearance. Odontogenic myxoma has got the step ladder or the tennis racket appearance. AOT has got mixed radiolucent radiopaque. There is no particular name for the AOT. Pattern name is not there. Whereas all the other have got a typical pattern. So bubble or honeycomb for amyloblastoma, snow-driven appearance for the CEOT, and the odontogenic myxoma is called as step ladder or the tennis racket pattern. So usually in radiology, one question typically comes from these patterns, okay, that we are supposed to remember. Okay, so remember one more as we are discussing about this odontogenic myxoma. First of all, I just want to tell you one important point that this odontogenic myxoma, why is it so much aggressive? Because this myxoma will have a ground substance. Called as the hyaluronic acid. And remember, this hyaluronic acid is responsible for aggressive behavior of odontogenic myxomas. Aggressive behavior of odontogenic myxomas is because of this hyaluronic acid. Okay, so that is about the odontogenic myxomas, and that is about the today's session for the MCQ discussion for oral pathology. Any doubts, you can definitely comment it, and then I'll get back, or you can post it on the WhatsApp, whatever is that. I'll just go through that and clarify all your doubts. So in the next session, we are going to see many more such MCQs where we are going to discuss the different MCQs from the various topics of the subject of oral pathology. Okay, thank you so much.